and I'll be talking to you about pathobiology, epidemiology, diabetic retinopathy, as well as lasers and steroids. So epidemiology of diabetic retinopathy in India and pathobiology of DME and PDR, it's a huge topic. I'll try to cover up as rapidly as possible. We know that we have progressed from the DRS, ETDRS, DCCT, the diabetic vitrectomy study, and then we have had multiple other studies which have happened over the time with the use of anti-VEGFs. Uh, we have really evolved, and so have we evolved in our imaging techniques and our surgical techniques from 20 gauge to 27 gauge. And we have now artificial intelligence, as Dr. Rajiv will tell us about how we can predict which patients are going to respond to our treatment and which may not respond to our treatment. Diabetes, in midst of all this pandemic, there's an epidemic of diabetes all over the world, and you can see the distribution of the diabetes. And India happens to be the capital of this diabetic world with a rapidly increasing incidence all over the world. Though it is said that UAE probably has a higher prevalence, almost about 27% in the population, but in India, average is about 18 to 20% in patients over 40, 45 years. So these are some of the prevalence studies reported, including the last one, which shows the prevalence is 18% reported from Shankar Netale, where Rajiv was involved in it. So an average incidence comes out to roughly between 15 to 20%, and this has covered both the urban and the rural population, though earlier we used to say that rural prevalence is a little less, maybe around 7 to 14%, but overall it's all catching up, and average is a huge population of diabetics in our country which need to be handled. And the best way to do that is to screen them. And this just really shows us that how much of our resources have to be spent on screening and treating these diabetic patients. And as ophthalmologists, we have a significant role. Now, this just shows when we compare the amount of expenditure that is required and that is being done in various countries. So this is the amount of expenditure in billion US dollars which is being spent, and the amount which actually India is doing than what is required. The estimated burden of diabetes is high, and thus we have to really manage our diabetic retinopathy and DME. Out of the total population, 8.3% of the people have diabetes, 35% of the patients with diabetes have diabetic retinopathy, of whom 7% will have DME. So this shows the amount of treatment burden in terms of anti-VEGFs. But most important is that we have to control them well with metabolically, and if we do that, the chances of our patients becoming blind is going to be less. Now, please remember, every diabetic is a potential candidate for diabetic retinopathy. 80% of diabetics need only to be followed and managed well systemically. Only 20% need active intervention by a specialist. Many a times they will come with symptomless because most of them have to be caught early. If we catch them late and they have symptoms like those of complications because of retinopathy, that's already late. Hence, it's important to screen them. That means a huge number of people have to have a fundus examination. So our aim as ophthalmologists, as retina specialists, should be to prevent the progression of diabetes and to catch them early so that we can treat them. This was a very important paper, which Rajiv may remember, which was published quite some time back, but it just showed that for sight-threatening diabetic retinopathy, the cutoff level for HbA1c was about 8%. So people normally come and ask us how much HbA1c we should maintain. At least we normally tell them it should be below 7 because the The International Diabetic Association, as well as the American Diabetic Association, the levels are falling on a regular basis. And right now it's about 6.1. But if you can keep our patients below 7, it is good enough. So anything below 8, the side-threatening diabetic retinopathy can be significantly reduced. Coming to a little bit of the pathobiology, it's a huge topic to cover, but basically to show this is the normal vasculature. There's loss of pericytes due to apoptosis with the endothelial outpouching, formation of the microaneurysms. We know what Stalin's hypothesis is, and in the patient of diabetic macular edema, there is an increase in the hydrostatic pressure because of increased BP. There's a decrease in the oncotic pressure because of proteinuria due to nephropathy. There is a capillary wall damage, as I said, because of loss of pericytes. And there is an abnormal leaching which leads to accumulation of intercellular fluid and because of capillary non-perfusion, neovascularization, and hence all these problems of hyperglycemia, which I'll be just alluding to. Just to represent it pictorially, there is capillary occlusion, which leads to capillary non-perfusion, and there is leakage. And this leads to macular edema or the retinal edema. And because of capillary non-perfusion, there is release of vasoformative factors, which we're all aware, and Dr. Dinesh should be talking to us on the role of anti-VEGFs, and this leads to the neovascularization. So there are 5 pathological processes which basically happen: formation of microaneurysms, increased vascular permeability, vascular occlusion, neovascularization and bleeding. There is contraction of the new blood vessels, scarring and retinal detachment, and there is, because of various reasons, there is altered neurotransmission. And when you have vitreous hemorrhage, you can have media opacities, which optically prevents vision from the patient from seeing. So this is a little busy slide, but however, there's a lot of metabolic changes which are involved in diabetic retinopathy. Suffice to say that there is role of VEGF, there's role of pro-inflammatory markers, there's increased vascular permeability, and there's angiogenesis, and there are neurogenic influences. So these are some of the biochemical markers in diabetic macular edema. For want of time, I will not go into the details of each. And we know that there is increased involvement of the advanced glycation end products. These are important, and this is responsible for the various metabolic problems that occur throughout the body, including diabetic retinopathy. So we know that there are diabetes has microvascular complications which occur in the brain, heart, and extremities, and microvascular complications that occur in eye, kidney, and as well as neuropathy. So it's important to monitor all of them together. And the most feared complication, if you look at people, it's the feeling of loss of visual acuity. I know it's very extensive, so there's short of time, but I think we'll cover this subsequently. And just to introduce that, we have all learned about CSME, those 3 criteria, but drcr.net divided it into a center involving DME and a non-center involving DME, which because the center involving DME is treated with anti-VEGF, while the non-center involving DME, we can treat with lasers. So this is just a pictorial representation of CSME. And I'll be alluding to this again in my second talk of how is the center involving DME is important, and why we should do laser for the non-center involving diabetic macular edema. This is further classification of the center involving diabetic macular